Okay, so I think we'll get going here. My name is Sanjay Patra. I'm a neurosurgeon at Spectrum Health, and we're just going to go through some couple of cases, updating everyone on some of the newer treatment modalities for epilepsy surgery. Again, Spectrum Health is in Grand Rapids. We're a level 4 epilepsy center. We do both adult and pediatric cases, which we'll highlight one from each today. We have 80 MU beds, and we're probably going to expand to 10 shortly. We have fMRI capability. We do ictal SPECT with Syscom. We have a 3T MRI scan, and we do SEEG with ROSA. We also have interstitial thermal laser ablation capability, and we do VNS, RNS, and DBS, although we have not done any DBS therapies for epilepsy yet. We're still kind of waiting for that technology to be approved by the FDA, hopefully. So we'll get into the first case, which highlights the use of parasagittal insular depth electrodes for the evaluation of potential insular lobe seizure origins. So this involves a 29-year-old right-handed male who started having seizures from the age of 13. His risk factors are really trauma at the age of 12, where he fell off a horse. He had no loss of consciousness. His father also had a history of seizures, although we don't have documentation as to exactly what kind of seizures those were. He had 3 types of seizures. The first one is a complex partial seizure, and this is his predominant seizure type. He'll experience right-sided numbness, starting from the arm and going to the foot. He'll also experience difficulty talking. He states that all of a sudden he can't hear very well. It's like somebody hit the mute button. He'll also experience ringing in the ears, as well as clonic right upper extremity movement, and the patient is unaware of these clonic movements. These episodes can last 5 to 10 seconds, and they occur approximately once per week, although recently they have been occurring up to 3 times per week. He also had a simple partial seizure where he would get numbness in the right hand. He'd have a period where he couldn't hear, or throughout this episode, he could hear and understand. He had a sensation of things speeding up around him. And these episodes would last 5 to 10 minutes, and they're occurring about 2 to 3 times per month. He also experienced secondary generalized tonic-clonic seizures, where the seizures would start off as a complex partial seizure or a simple partial seizure, and then progress to a generalized tonic-clonic event. These would generally last 1 to 2 minutes. Prior to workup, he had only experienced a few of these, but in the months preceding the phase 2 surgical evaluation, he was experiencing these generalized events about once per month. History-wise, he had been on multiple anti-epileptic medications. He was currently on Dilantin, Lamictal, Trileptal, and Keppra, and he was experiencing some side effects of dizziness and fatigue. His physical exam was normal. Given the refractory nature of his seizures, the effect on his quality of life, he wanted to pursue pre-surgical evaluation. He had a Neuropsych assessment done. IQ was at the 27th percentile. Verbal was at the 25th percentile. His language function was very low, only at the first percentile for naming and word fluency. So overall, the interpretation of this was that the Neuropsych testing was kind of lateralizing him to the left hemisphere. He was admitted to the EMU for continuous EEG monitoring. He had 3 seizures recorded during his visit. These are similar to his typical seizures with right-sided arm numbness. He We also noted a buzzing sound in the ears, became unresponsive, and we also noted some hyperventilation followed by clonic movements of the right face and head. The EEG was read as a left temporal onset for these events, and interictal EEG also showed left temporal sharp waves as well as some low voltage, higher frequency beta activity interictally. He had a PET scan, which was normal. He had an MRI scan, which was also read as normal. So we proceeded with the MEG scan. The MEG scan was interesting. It showed a pretty good coherence of spikes in the anterior insular region as well as the superior temporal region and the temporal opercular region. It was also involving the transverse temporal gyrus adjacent to the temporal operculum. So we have a picture depicting this. Hold on. As you can see, there's some spike clustering in the anterior insular region, but more focused in slightly below the insula and the temporal operculum rather than in the frontal region. So the recommendations from our multidisciplinary epilepsy conference was phase 2 evaluation with intracranial monitoring using subdural electrodes to cover the lateral temporal, frontotemporal, and parietotemporal convexities, and as well as covering the insula based on the MEG findings and some of the semiology as well. So just as a little refresher, insular lobe epilepsy involves, classic insular lobe epilepsy involves auditory hallucinations, motor and sensory pharyngeal symptoms. Patients can have a sensation of choking, body paresthesias. Sometimes these paresthesias can be painful or unpleasant, dysarthric speech, as well as autonomic findings as well. So he had a couple of components of this in his semiology as well, so it was enough that we needed to at least rule out an insular onset. So what are the options for insular lobe coverage? There's essentially 3 ways you can do it. First way is to do a craniotomy, split the sylvian fissure and place strip electrodes and depth electrodes directly within the fissure under direct visualization. The second method is a classic Telerac method for SEEG, where one would place orthogonal transopercular electrodes. This methodology obviously has a risk of vascular injury given the abundance of vessels within the insula and in the sylvian fissure. Another method that's been fairly recently published using a Lexel frame is the use of parasagittal depth electrodes. And this method potentially has the advantage of avoiding some of the high vasculature within the sylvian fissure. Challenges with these approaches, the Lexel frame-based SEEG approach, when you're combining that with the craniotomy, the frame does hinder your approach, especially if you need to do a fairly large craniotomy. Our experience using the robotic arm, really, although there's some adjustments you have to make in positioning, overall you are able to do a good-sized craniotomy, and it doesn't really restrict you too much. The other challenge we face is brain shift. If you do a craniotomy and then you place electrodes, there is a significant amount of brain shift that can occur depending on the patient, and it can affect the accuracy, especially if you're using long trajectories such as parasagittal insular electrodes or Spencer depth electrodes in the hippocampus. So it's advisable to do these electrodes prior to the craniotomy if possible. So our operative plan was to use robotic SEEG for parasagittal depth electrode placement, followed by open craniotomy for open depth electrode placement. These are non-SEG type electrodes into the temporal operculum using ROSA as well, and then placing our subdural strips and grids covering the mesial temporal convexity, frontotemporal, and the temporal parietal regions. So what is the typical workflow for this type of case? We always get a preoperative MRI with GAD. Again, the GAD is important when you're planning your trajectories to view the blood vessels and avoid any penetration of the blood vessels and to decrease your risk of hematoma. Patient is then placed under general anesthesia. For this case, we did end up using bone fiducials, which we felt was necessary for improved accuracy. And with the bone fiducials, you want at least 5. They should be bilateral and cover some of the working regions. Again, once you've registered, you can take out the fiducials. We then get a CT scan, register using the bone fiducials, and then fuse a CT and MRI scan. We then plan all our trajectories, and once everything is planned out, then we proceed with placement of the SEG parasagittal insular electrodes, and these are just your classic SEG bolt type electrodes. Now, you do have an option of doing an O-arm shot after this to confirm placement. For this case, we actually didn't do it. We were pretty confident with the level of accuracy during the registration process. But for instance, if you're placing Spencer depth electrodes for neuropace, you may want to consider doing an O-arm shot, prior to finalizing your implant. But for this case, we had a good registration. We're satisfied with placement of our electrodes. Then we did a frontotemporal parietal craniotomy and used the ROSA for placement of orthogonal temporal opercular electrodes, and these were non-SEG depth electrodes. We did this during the first part of the case, again, to avoid as much brain shift as possible, although the craniotomy had been done at this point, and then we placed the subdural strips and grids. So this is our a cartoon of our initial implant, and you can see here these are the grids covering the temporal convexity, parietal convexity, and some of the occipital convexity. We also had basal temporal coverage here, mesial temporal coverage here with a strip electrode, as well as a basal frontal coverage. The temporal opercular electrodes are labeled here and here, and those are through the superior temporal gyrus. The posterior one was traversing Heschel's gyrus, or the transverse gyrus, as this was an area of activity during the MEG. The parasagittal electrodes will be better visualized on the next slides. So once we place our electrodes, we get a post-operative CT scan, and then fuse that with the preoperative MRI scan and get a rendering of exactly where all the contacts are. In this case, we also fuse the preoperative fMRI, and the yellow here is depicting the language area, the receptive language area, and actually we had a pretty good matching of this area. Did the actual brain mapping at the end of the phase 2. This is one of the parasagittal depth electrode trajectories. As you can see, we're covering the anterior portion of the insula, and the more posterior trajectory you'll see in the next several slides here. That's the deepest contact, and we're moving up. And as you can see, we had a very good coverage of the anterior insular region. And again, this was the area of activity where we saw the clustering on the MEG study. So he was in the EMU for about 3 weeks. He had several seizures, and he ended up localizing primarily over the superior temporal gyrus with some early onset in the basal temporal region as well. There was no early involvement of the parasagittal insular depth electrodes. He ended up not being a resection candidate due to receptive language in the areas of seizure onset. So the final treatment plan was to proceed with a NeuroPace implant with one strip in the basal temporal region here, and another strip on the superior temporal gyrus here. He also had some earlier activity posterior to the strip on the superior the superior temporal gyrus. So we placed 2 additional strips posterior to this and capped them off. As you know, with the NeuroPace, you can only have 2 active strips inputting it. So in the future, if the thought was if those strips were less effective, we could convert them with the other inactive strips to see if we could get any additional coverage. So he's now about 14 months follow-up. Initially, he did continue to have seizures, but as we learned, his seizure onset pattern and the optimal delivery of current to abort the seizures for the past 5 months, he's been essentially seizure-free. Again, prior to the RNS implant, he was having 2 to 3 simple partial seizures per week, 1 complex partial seizure per week, and 1 grand mal seizure per month. So over the past 5 months, he's been only having some auras about every other week, consisting of some right arm tingling, some difficulty hearing, which can last a few seconds, but he remains conscious throughout these episodes. So overall, a good result for him so far. The key points about this case is that the ROSA allowed for really highly accurate placement of the depth electrodes parasagittally into the insula. Again, these are very long trajectories, so it does require a high degree of accuracy and precision. We also had unhindered access for traditional craniotomy for subdural coverage. And this involved several depth electrodes, and the use of the robotic arm definitely decreased our operative time. Once all the planning was done, it really moves between trajectory to trajectory within seconds. And in a traditional SEEG case, you could place really only takes about 5 minutes per electrode once you're planned out. So that was the first case, and we'll move on to case number 2, and this is a pediatric case involving an 8-year-old girl. She'd been having seizures for the past 3 years, starting at the age of 5. These were gradually increasing in frequency, and the point before surgery, she was having them almost daily. The longest previous seizure-free period was a few weeks. So her semiology consisted of abrupt tonic posturing of her upper and lower extremities with some internal rotation. There would be some grunting, and she would not be able to move. There was some behavioral arrest, as well as oral automatisms. These would last about 10 to 30 seconds and occur, again, almost daily. She had had about 4 previous generalized tonic-clonic seizures in the past, and these lasted about 15 minutes. So these were current meds: anisomide, trileptal, and clonazepam. For preoperative evaluation, Neuropsych exam was non-lateralizing or localizing. However, we did have serial exams on her from the onset of the seizures, and it showed a significant decline in her academic performance, particularly in her reading, since the brain lesion was identified. Okay. She had a PET and CT scan that showed focal hypometabolism in the posterior parasagittal left frontal lobe, and this was corresponding to the region of the abnormality seen on the MRI scan, which I'll show you in the next few slides. Her video EEG showed focal epileptiform discharges out of the left mid-temporal region with increasing frequency during sleep or drowsiness. She had 2 seizures during her stay in the EMU, and they were both read to be out of the posterior quadrant and possibly due to secondary to deep focus. So I will show you her MRI scan, and you can see here, first on the sagittal, this is a T1 weighted image with gadolinium. This is the location of the lesion involving cingulate gyrus. And this is pretty far posteriorly in the frontal lobe. There's some contrast enhancement, and you can see it is involving some of the corpus callosum as well. This is a T2 coronal section, again, showing the lesion right here, involving both the cingulate gyrus and the corpus callosum. So she was discussed at conference, and the consensus from the group was to proceed with either surgical resection or laser ablation. So surgical resection for lesional epilepsy is the more tried and true method. You get definitive removal of the lesion with margins, and it's more likely to produce seizure freedom. Based on the studies, the seizure freedom rate can be as high as 80%. Now, there is some morbidity associated with surgery, particularly in this area with the, it's quite deep. It's near the motor area. You'd have to approach interhemispherically. So there's a chance that she could develop, leg weakness or even, mutism from supplementary motor area, brain retraction. And it's also an 8-year-old and the kind of cosmetic issues that go along with, going through a procedure like that. MRI-guided laser interstitial thermal therapy or laser ablation. It's a less morbid approach. However, there's less data on it. There has been a study by Curry that reported on 5 pediatric patients retrospectively, which showed good clinical results, and all 5 of them were actually seizure-free. But then the follow-up again was only 2 to 14 months, and you don't get a complete lesion resection. So taking all this into consideration and given her age, and she was in the middle of the school year, we chose to proceed with the laser ablation. So our plan was to use a ROSA to obtain a stereotactic biopsy, followed by laser ablation and the MRI scan. So the workflow of pediatrics is a little different. Proceed with general anesthesia first, then an MRI of the brain with GAD, followed by a CT of the brain. And for this case, we use the laser registration system. Initially, when we did a lot of these cases, we used more of the fiducial registration system, but as we became more confident in the accuracy of the laser registration, currently, if the patient is supine, we almost always just use the laser registration. We fused the MRI and the CT scan. We planned our trajectory. We did the biopsy, and then we took the patient into the MRI scanner for the laser ablation. So this is depicting the probe, the fiber optic probe in the lesion, and this is a post-ablation DWI sequence showing the area that was ablated. So what was her outcome? Again, this is pretty early in her case, but she has been seizure-free for about 4 months. Again, she was having daily seizures prior to this. Her pathology, again, was fairly benign ganglioma, but she will require continued surveillance. So the key points for this case was that the ROSA allowed for minimal morbidity compared to open resection. Now, you could technically use a Lexel frame for this as well, or even another navigation system, but in our experience, when we really want to be accurate right in the middle of the lesion, we wanted to proceed and use the robotic system for, I guess, ease of use and accuracy. Again, non-fiducial laser-based registration was accurate as well. We were able to obtain a biopsy, and she was able to be discharged the next day. So, and that's it. And if anybody has any questions, I'm happy to take them now. Well, it's not so much, you can set your margins and you get a postoperative diffusion-weighted imaging after the ablation, but the real, kind of issue is we don't know the long-term follow-up, of how well it's going to halt the tumor growth compared to an open surgery. But yeah, according to our postoperative DWI, we have a good margin on that area. It's more the long-term follow-up, at 5 and 10 years. Is it going to be as good as surgery? And that we don't know yet.
How many cases are you doing ablation versus resection right now?
Ablation is still limited. I mean, most of our ablation is done in the setting of metastatic cancer patients who have already undergone radiosurgery or radiation therapy and are progressing despite that. I mean, those are the majority of the ablation cases, but we do occasionally do it for epilepsy patients such as this, or periventricular heterotopias, those are deep lesions. So we've done those cases. Hypothalamic hamartomas, another good case where the laser, really diminishes the morbidity of that procedure. And we've used it for the amygdala and hippocampus as well.
And then you said the accuracy of the laser, as time went on, you became more confident with it. What kind of accuracy range?
Well, I think we've been getting, about a millimeter or even sub-millimeter with the laser. It really follows the exact trajectory. And we have verified this with, particularly in the case where we did bilateral Spencer depth electrodes for a NeuroPace implant. We did a post-implant O-arm spin that showed really that we were right on target for that trajectory. No, well, a lot of this is done by our epileptologists, so and it is not right away. So they really kind of fiddle around with it for the first several months. A lot of our patients don't have good seizure freedom until they're about 3 or 4 months out from the procedure. And then we're finding, as other centers are finding over time, the efficacy of the treatment is improving, and more patients that were initially just getting minimal relief or 50% relief are actually becoming seizure free. Not everybody, obviously, but as our epileptologists are getting more familiar with the parameters, we find that we're finding that things are improving for the patients. Yeah, fairly similarly, from what the epileptologists are telling me. But again, there is some variation as far as a lot of it is picking up, when to start stimulating too. Most of the time you can stimulate at higher frequency where the patient won't sense a paresthesia or won't have an adverse reaction to the stimulation. So some of it involves making sure the patient doesn't feel an adverse response, especially if you're in eloquent areas. We haven't actually switched one yet. So far we've been just using our primary location for the RNS, and we haven't had to switch any yet. Now I would say us adding additional electrodes, probably only about a quarter of our patients who get an RNS will have extra electrodes. Most of them we can localize it, with enough confidence that we're okay with, either a strip or a depth electrode. Any other questions? Yeah. We've done about 20, roughly 20 so far. Yeah. Yeah, we tend to have a population here that have already gone through surgery and then they end up getting referred to us and they've had 1 or 2 or 3 resections, and most of these patients aren't good resection candidates, so they end up having an SEG type evaluation followed by an RNS. Oh yeah, I think for sure. I mean, there's patients, that have been in the practice prior to RNS that were essentially had intracranial evaluations and then nothing was offered to them because they're thought to be bitemporal or, have several foci. But, a lot of these patients are coming back now and being reevaluated. Oftentimes we just don't go by the old phase 2 or intracranial evaluation. We'll repeat and do an SEG and then proceed with RNS based on that. And I think the ablation has helped too, especially in these patients with deep heterotopias, who you don't want to go in, especially if they have 2 or 3, you don't want to go in there and put them through that open surgery. Now with the, I had a patient that had 3 heterotopias. Okay, thank you.